All right, so what do you guys think of the test? Easy, tough, terrible, great. I've heard it all, so you don't have to worry about hurting my feelings. And again, this is like the second revision of the test, right? So last year's class was my guinea pigs, and I got to kind of refine things a little bit. So you should feel like it's not, some things work, some things don't. That's okay. That's why we go forward. So there were 2 high miss questions that I did partial givebacks for. However, there's some other ones that were usually we consider high miss to be less than 50%. So there was a few that were like in that 50 to 70% range that I did want to cover to make sure you guys all had a good understanding of the topic, to make sure when it comes up again, say in pathophys or in CMS, you guys will have some good understanding of it. Any questions I can answer off the bat though?
Yeah.
Yes.
That septic hypotension.
The septic hypotensive patient. Boy, that one was. Woo. Okay. That was like the lowest I'd ever seen a question actually being answered correct. And that's, again, not your fault. When I see a question, and I'll just tell you, it was 15% answered correctly. That's abysmal. That either shows that I taught something totally incorrectly, or the question was such that you guys were unable to get the right answer, right, or come to the right conclusion. That was one I did a partial give back for. That was one of the ones I gave a partial give back for. So let's work through that one, because I think that one's an important concept. It's probably one of the more important concepts on the test to understand when you're dealing with these kind of really sick hypotensive sort of patients here. So let me get to it. Yes, it should have already gone through. If you feel like you did not receive credit, please come to me and we will go through it and we can discuss that. Canvas, we're still trying to get used to it. We're still working through it. And so sometimes it does take a little bit of time to update, but something could have gone wrong. So we can go through it and we can check that. Or you just may have answered them correctly in the first place, in which you got no extra credit, right? So only do partial give backs, I didn't do full give backs for the questions. Okay, so let's look at this. Let's say we have a 33-year-old patient, right? So they're hypotensive. Secondary to, let's say, sepsis, right? So they have sepsis, they're hypotensive, right? All right, which of the following would have occurred due to regulation of blood pressure in the patient, okay? So let's see what are some of the things that are going to be happening to that patient, right? So what do you think is going to be more predominant, their parasympathetic or sympathetic sort of nervous system? They're hypotensive, they're about to die because they're not perfusing their brain and their heart. Perhaps it's the fight or flight sort of response, right? It's a fight or die sort of situation here, right? So again, the body's saying, hey, we need to keep blood flow going to the critical organs. Other things can take a hit, right? So in this case, what neurotransmitter are we going to release? Norepi, right? That's going to be one of our predominant things that are going to be released from the sympathetic nervous system, saying, okay, let's help to regulate the blood flow. Because where do we want blood to go to? The brain and the heart predominantly, right? We can survive without other things. We can survive without sending blood supply to the GI tract right now. Where else might it want to cut blood flow from? So we said GI, where else? The kidneys, right? Because what are the kidneys are predominantly doing in those situations? It's getting rid of fluid. This patient's hypotensive. We probably want to hold on to fluid in this case, right? So we are going to cut blood flow to the kidneys. How is that going to happen? So norepi is going to be released. What is that going to do to the kidneys? It's going to cause afferent arterial constriction, right? So what does that do to my GFR? It decreases it, right? Because again, now I have less blood flow getting actually into the glomerulus, less filtrations occurring there, which means my blood volume should do what? It should try to increase, right? Because again, we're trying to make sure we're not filtering out all that fluid because we'd like to keep it in our blood supply, right? So you're going to find that, and is that intrinsic or extrinsic regulation? It's extrinsic, right? That's the brain saying, hey, we need to keep this blood around. We need to get the blood pressure back up. Kidneys are going to take a back seat for a second, okay? So that's what the primary thing is going to happen. That was the correct answer. That's what you would see would occur here. Now, the question is, okay, well, the kidney's now getting less blood flow because all this norepinephrine is constricting the afferent arterial. What does the kidney want to do now? What system is it going to activate? The renin-angiotensin-aldosterone system, right? Good. So what does the kidney release? Renin. What did the answer say? Angiotensin 2. Okay. So it was a one-word sort of trip up. And the main point I was trying to get at was that, hey, renin gets released here from the kidneys. Angiotensin 2 gets produced elsewhere. Now, was that kind of mean on retrospect? Now I'm looking at it? Yes, that is why I gave you credit for that answer now, okay? So I said, okay, well, they at least got the concept down. They understand that when you have decreased GFR due to things like hypovolemia or sepsis, the kidney should be responding by increasing activity of the renin-angiotensin-aldosterone system, okay? So that one I did give credit back for. The other answer choices were kidneys will attempt to dilate the efferent arterial to increase GFR. Does that make sense? No, you try to constrict the efferent in order to get better GFR. So that would not be the correct answer. And then the other case would be the adrenal medulla would secrete aldosterone to increase aquaporin channel expression. Why was that one wrong? ADH, yeah, ADH is what will stimulate the aquaporin. So again, ADH will be increased when you have a patient in this sort of situation. However, aldosterone is not the thing that increases the aquaporin channel expression. Aldosterone would do what, on the other hand? It would try to increase salt and water reabsorption at the expense of potassium. Good, right? So again, there's another question later on that's asking about angiotensin 2. If the levels were high, what would one of the downstream effects going to be there? And that would be the case where you're actually going to be losing potassium because you have kind of upregulated aldosterone being released there. Make sense? Yes, sir.
So if that would have, you would have put
that would have been correct in that case, right? So again, probably a little too tricky for my purposes. It kind of was punishing you for knowing the concept, but not getting those very minute specifics down. So because of that, I still think it's important you know there's renin being released from the kidneys. However, I don't think you should be punished for that. So that's why I gave partial credit for that one. Okay? Make sense? Okay. I want you to think I'm mean, but not that mean. The other one I gave partial give back for was about liver function. Where does actual phagocytosis of bacteria occur? In the Kupffer cells, right? Otherwise, specialized type of macrophage, right? The hepatocytes themselves don't do the phagocytosis. They'll break down other products, right? That, again, I think was probably a little too nitpicky, so I said, okay, I'm going to give you partial credit for that answer as well. The actual correct answer was saying, a bile outlet obstruction would be indicated by increasing levels of conjugated bilirubin, because, again, that's a more water-soluble form. You would be excreting out the bile. So those are the two partial give-backs that I gave credit for there, okay?
I do have a question on one
Yes.
of them. The one where the person was in metabolic alkalosis and the intercalated cells.
Yes, that's another one I wanted to get to. So the question was, okay, so you have a patient who's trying to fix their gut. You have patients who will try home remedies all the time, so this is not completely out of the norm. So say I'm going to take a bunch of baking soda. I'm going to take a bunch of baking soda to try to fix my gout, right? If I make myself alkalotic, maybe these uric acid crystals will be less likely to precipitate out. Maybe that'll fix my gout, right? They're probably not thinking that far ahead, but they read online, like WebMD, RU, whatever, says, hey, go ahead and eat some baking powder. Okay, so again, this person has induced a metabolic alkalosis, which was pretty clearly stated in the question there. The question, how are the kidneys going to respond to that? Okay, so I'm in an alkalotic state. What do the kidneys want to do? They want to secrete acid, or they want to secrete bicarb? They want to secrete bicarb, right? So that way we bring the pH back down to a normal range. What cells are going to do that? The type B intercalated cells, right? Type A, I think acid, releasing hydrogen ions. Type B, I think basic, releasing bicarb. That makes more sense on that one. And that was actually pretty even split between who answered type A and who answered type B. That question was, okay, well, I'm in an alkalotic state. I have too much bicarb. How am I going to get rid of that to bring things back into order, right? So again, kind of digging one step further, because I could have asked a simple memorization question, which cells secrete bicarb, right? That would have been one level of it. However, take another step forward and say, well, let's apply this to a patient who's now thrown themselves out of homeostasis. How do we get them back into it, essentially, okay? These are the type of questions that are going to become more predominant as you go forward, especially like with CMS and other things where you have to think, okay, here's my patient situation, here's the vignette. How do I apply what I know about the pathophys, the physiology, the pharmacokinetics, all the different things are going to kind of coalesce into deciding how am I going to manage this patient. Okay. What other questions can I answer? Yes, sir. No, that's totally fine. Yeah.
There was one in which the answer was dilation of efferent arterioles.
Mhm.
One of the options was dilation of afferent.
Mm-hmm.
I don't remember exactly what the question was.
Okay.
I remember that I was really surprised that I was wrong.
Yes, so there's one question talking about if you have increased levels of angiotensin 2, what would you expect to see? And this is going to be, and angiotensin 2 would do what to the arterioles? Constrict which ones? Efferent, right? Because again, angiotensin 2 gets released or gets formed when your kidneys are in a state where they're saying, hey, we don't have enough blood flow here. We don't have enough sodium and a volume being detected by those juxtaglomerular cells. So they're going to try to increase the GFR. And in this case, they're going to increase GFR by angiotensin 2 constricting the efferent arterioles. Okay, that's going to increase that back pressure on the glomerulus and increase the hydrostatic pressure there, and which will increase the GFR. Makes sense? Now, what increases, what will dilate the afferent arterioles? Prostaglandins, right? Which is why if you have someone who takes something like an NSAID, like ibuprofen, you decrease prostaglandin synthesis, and then you cause that constriction there, and that's why you can see acute kidney injury. It's one of the big side effects you worry about for patients with bad kidneys to begin with when you give them an NSAID like ibuprofen. Okay. Yes, sir.
So I remember on the Kahoot, there was the same scenario with the angiotensin 2, but the answer was arterial dilation
Mm-hmm.
as opposed to efferent constriction?
I'd have to go back to the Kahoot, but I'd probably ask something about if you blocked the angiotensin II receptor, what happens in that case? You see the efferent would dilate, right? And so that's, again, another case where if you have patients with bad kidneys, if they are normally chronically dependent on angiotensin II to cause that constriction of the efferent arteriole, and I give them something like an angiotensin receptor blocker, that will then alleviate that effect, right? So it kind of gets rid of the angiotensin II effect. Now it's on this dilation, decrease in hydrostatic pressure. Again, I can see acute kidney injury. Overall, that's a good thing for those patients. And typically what we'll do for patients like that with poor kidneys is that we will start them on a low dose of those sorts of drugs and just kind of gently ramp it up. So that way, that's good because, again, that's less stress on the glomerulus. We can decrease that pressure on the glomerulus. That means they're going to be functioning for longer because we're not putting them under as much stress in those cases. Okay. Any other questions on the test? Yes?
For the Nexus, if the same kind of questions are going to be applied, if we get a little bit more practice with, like, you throwing out some questions like that?
Sure, and that's what I try to do with the Kahoot. Yeah, that's what I try to do with the Kahoot. But if you would like more, I will try to think of more. But again, you guys can come up with these scenarios too, right? So again, you can think through, okay, well, if I change this, what do we think would happen downstream? If you kind of come to an impasse, you're like, well, actually, I have no idea. Let me go ask Professor Wood. I can try to elucidate that. But yeah, I'll try to add a few more of those kind of clinical scenarios into the Kahoot to see if we can get. The Kahoots are sometimes tough because I have a character limit I have to deal with, right? So it's kind of like, they're not like Twitter where they increase their character counts. I can't like write these really verbose sort of scenarios. So unfortunately, I'm a little bit limited by that. But yes, I will try to include more of those. Any other questions?
I was kind of confused for angiotensin II. Would you say that it like increases GFR, but there's not a net increase because it's really just trying to keep it the same?
It can increase GFR, right? So for instance, if I had a case where, say I was hypovolemic, so say my blood volume went down, you may find the kidneys were going to respond by upregulating angiotensin II, and in that case, that would increase GFR, right? Because that would go from having a low volume state, but by increasing the hydrostatic pressure by closing down that efferent, then yes, that would increase GFR in those cases.
There's like a slide that just said it tries to prevent it from dropping.
Yeah, so in those cases, you're right. So again, that's basically what we're seeing where in some cases you're trying to keep just the norm, right? That's why we had that intrinsic autoregulation, right? That's why we try to, actually that's a good point because someone else said they were thinking that the hypotensive question was kind of counterintuitive because they were like, well, you said in cases of hypertension, the afferent arterioles are going to constrict. That makes total sense as well, right? Because that's the intrinsic autoregulation. Just like your brain doesn't want to have too much pressure coming in, the glomerulus doesn't want to have too much pressure coming in. So in a hypertensive state, it would also constrict to try to prevent that having too much hydrostatic pressure, okay? However, in the case of extrinsic autoregulation, when you have the brain saying, hey, no, I need to take over control of the blood flow here, it's going to shut down the afferent as well because that will help to increase blood pressure more systemically. Okay. Yes, but typically angiotensin II is trying to maintain homeostasis. That's why the kidneys are releasing renin and to eventually form angiotensin II. In those cases, we have low GFR to try to build that back up. Again, that's all that kind of that balance there. And then as the GFR kind of comes back up, then angiotensin II level should go back down to somewhat north of a normal level. Yes, sir.
I don't know if you mentioned this, or I'm not sure I missed it, but does angiotensin I serve any purpose other than being converted to II?
If it does, I don't know that it has any clinical bearing on anything. It's just kind of a inner conversion to get to eventually angiotensin II. Any other questions? Fantastic. Did everyone buy their tickets to the gun show? About muscles today. Just waiting all morning to do that one. All right. So this is the last section of physio. We're going to talk about muscle physiology first here, then we'll get into various parts of the nervous system. We'll talk about the CNS, the autonomic nervous system. I try not to say ANS because I'll say that too quickly and then it sounds like something else. We already covered GI. We don't have to worry about that, right? You guys are 75% done. Yay. You're almost out of this one. All right. There should be more, because we want more physiology. No, nothing? Okay, that's all right. Okay, so we're going to go over our skeletal muscles. This will be the predominant thing we'll talk about today. We're going to talk a little bit about the smooth muscle towards the end of this section. I'll see how much I can get through. All the sections should be posted up on Canvas. Do not look at the paltry number of slides in this section in total and think, oh, this is going to be a breeze. There's a lot to talk about in all these. So I think like one of my sections I looked at was like, oh, it's only 36 slides, but we can probably spend 2 hours talking about 36 slides when we get into things like neurotransmitters. So just buckle up, all right? Anywho. Skeletal muscles. All right, so basically, skeletal muscles do what for us? Now move some bones, right? So again, that's why I call them skeletal muscles. Generally, we're going to find both ends of these are going to be attached to the bones by tendons. Absolutely. So tendons, you guys have covered most of this already, so I'm not going to belabor these points. We're going to get into the actual physiology, how do we actually make these things move around. But basically, when the muscle is activated, we're going to find it's going to cause contraction, and that causes it to shorten, as you might imagine. And so again, by placing tension there on those tendons, you're going to be able to pull that bone up and then cause actual movement to occur here, right? Basically, wherever the muscle is actually attached to, the bone that's actually doing the moving, is going to be the actual muscle, and wherever it's attaching to cause the movement is going to be the insertion here, and then wherever the bone is actually connected to that's not moving is going to be considered the muscle origin in these cases, right? So again, if you imagine here looking at the biceps muscle, you're going to find the humerus in this case would be, say for instance, the origin, but then say the radius would be the insertion, okay? So we're going to find that we can have different movements that occur here based on kind of how they're attached. Obviously, flexors do what? They flex, which is going to cause a decrease in the angle of a joint, right? And then you can also have extensors that would increase the angle of the joint, right? So for instance, and again, we're going to talk a lot about like opposing muscles, and it's important to make sure that we keep these actions working appropriately, right? Because again, when I say, for instance, when I flex my bicep, do I lose all tension in the tricep? It doesn't go completely flaccid, no, because we're going to find that you are going to have muscles being activated kind of at all times, but it's important to understand, like, okay, which one's going to be more predominant, which one's going to actually cause the movement to occur here. So in this case here, we're going to find that we can have antagonistic muscles, so for instance, having the biceps being one side of that, and then we can have like the triceps being on the opposite side, right? So again, this would be the flexor, the triceps would be the extensor, right? So I can increase that angle in my arm there. Okay, and again, we're talking about the main muscle responsible for movement, going to kind of be the agonist or the prime mover, and then whatever's kind of opposing that is going to be the antagonist. And again, we're going to find some of this is going to be under our conscious control. Some of these things are going to be much more mediated through reflexes in the spinal cord. So for instance, when I'm standing up here, am I constantly thinking about, okay, shift my weight this way, shift it this way, okay, make sure I don't fall over on my face? No, a lot of that's taken up by a lot of reflexes that are handled in the spinal cord. So we'll look at that a little bit later on, see that innervation, how that works. Okay, so you can kind of refer back to this table again. Have you covered this in anatomy, I imagine? All right, so I'll just cover this very briefly here, but you can. Again, we're having flexion, as we're actually going to be decreasing the angle here. Extension is going to be increasing the angle, right? Already talked about that. With abductors, you're taking something away. So I think about if you get abducted, if you're in that Liam Neeson movie. Taken away, right? Think about the abductor, and then the adductors, which just means kind of bring it in, right? So kind of bring it back. Again, that's how you can, a good way to think about those crazy thigh machines in the gym or something. Like, okay, which one's the abductor, which one's the adductor? Think about Liam Neeson. That usually leads me the right answer most times. Anyway, we have levitors and then depressors. Levitors do what? Lift things up, and then depressors, it's usually being lonely or sad. No, I'm just kidding. Those usually bring things back down. Okay. Very self-explanatory. So we're going to have rotators. Again, you have internal rotators going to be twisting things more medially. External rotators twisting things more laterally. Kind of makes sense there. And then also we can have things like sphincter muscles. And again, are sphincter muscles usually attached to any kind of bone? Generally no. And again, are all of these under conscious control? Not necessarily, right? So we can't really control the lower esophageal sphincter tone. However, we can do control things like the external, rectal sphincter. We can control things like the external urethral sphincter. So in some cases, it just depends. A lot of this is going to be under involuntary control, but we have a few that will be under voluntary. Again, whenever I talk about sphincter tone, it's usually what I'm referring to is like just how tight are you puckering up if something bad happens, right? So we're talking about like if you ever hear me talk about like a TCA overdose or something, I always talk about my sphincter tone going up. Those are like really dangerous patients. So you may hear me reference that every now and then. Anyway, so let's look at the actual function itself. What's causing these to contract? So let's look at the structure of the muscles in more detail here. So again, most fibers typically extend the entire length of the muscle, as you're going to find here. And so we're going to find that within the plasma membranes, we're going to have the sarcolemma. And that these all tend to be fused together, right? So again, especially fused with the tendon fibers towards the end of the muscle before it connects onto the bone there. So let's look at kind of the breakdown here. So again, we have some guy trying to impress somebody, looks like. And you're going to have the muscle in total, right? And then we can break down that muscle into individual muscle fibers itself, right? So we're going to kind of go deeper and deeper down as far as structure goes. So you get the individual muscle fiber. These can then be broken down to the actual myofibrils themselves. And have you covered this specifically in anatomy? Okay, good. So this is all new material for you. Fantastic. So when we actually break down the myofibril even further, we're going to find you kind of get down into these individual functional units, and these are going to be called the sarcomeres here. So basically, and I'll go over each of these details in a second here, all these different discs and bands and things like that. But you're going to notice that the sarcomere is basically the functional unit of the muscle. This is what's actually causing the actual contraction or relaxation to occur in all these individual sarcomeres. Okay, this is where we're going to see our actin or our myosin are going to be interacting with one another to cause contraction or relaxation, as the case may be. Okay. And again, when you have these kind of alternating stripes of dark and light bands, what do we call that? Striations, right? So again, we see skeletal muscle, striated muscle. This is what we're referring to. Is this kind of alternating these bands here. And I'll go into more detail on these in just a moment. So basically, we're going to have our eye bands, which are going to be considered the light bands. I think eye bands. I don't know, that's how I keep it in my mind. But basically, these are going to be sections that only are going to contain actin filaments. Okay, so again, the actins are going to be these very kind of tiny, or at least smaller in diameter, sort of muscle fibers here, right? See the actin molecules. And then the A bands are going to be these dark bands. So I think dark, again, however you memorize this stuff is up to you, but this is just the way my odd mind works. The A bands, which are going to be the dark areas, are going to include your myosin and then the overlapping actin, right? So again, these phases, or this sections here, these are going to be kind of the dark areas where you actually have the myosin. Notice the myosins where you actually have the heads here. This is what's going to actually cause the movement of the muscle when it contracts itself. But these are the dark bands. The eye bands are going to be the light areas where it's only actin showing up there. Okay. The Z disc, or the Z lines here, are going to be these dark lines in the middle of the eye band. So you can kind of notice here, if you look at this eye band, you'll see here there's a Z disc right in the middle here. This is basically where the actin is going to be attached on either side. So basically you see that basically the sarcomere is going to be delineated based on the Z discs. Okay, so from one Z disc to another is going to be considered one actual sarcomere. Okay. And so again, that's where the actin is going to be attached. This again would be the Z disc in this case. If you were to kind of explode that out, and so you can see where the actin is actually attached to. Okay. There's also going to be this titin that is going to attach to the myofibrils here, and kind of notice the springy sort of structure it looks like it has. That is its function. It's basically to act kind of like a spring to make sure things kind of go back to their original size. We're going to look at size of the sarcomeres and how that has an effect on muscle tension and the actual strength of contraction a little bit later. So kind of keep that in the back of your mind. So again, as I mentioned, sarcomere is any area between the two Z discs. So again, Z disc will kind of mark off each sarcomere there. And I mentioned that tightens that springy protein holding the actin and the myosin in place. So basically, it kind of keeps everything together. Actually, when the muscles were originally forming, that's what's actually forming the template there, is that tightens. It's very important there. And then we're going to have the sarcoplasm. Basically, it's all the fluid is going to be actually within the sarcomere itself. It's going to contain a lot of different electrolytes, so we're going to look at things like potassium, magnesium, phosphate, a lot of mitochondria here. Why do we need those mitochondria there? You need ATP. We're going to say ATP, just like anywhere else you need energy to make something happen, the same thing is going to be applying here. So we need lots of mitochondria. We'll look at different types of muscle fibers and the numbers of mitochondria and other factors there. I'm sure you've heard of like fast twitch and slow twitch fibers. We'll look at what the differences are between those a little bit later. Another big thing you're going to find within the sarcoplasm is going to be the sarcoplasmic reticulum. What is that going to hold on to? A lot of calcium. Calcium again is going to be huge in causing actual muscle contractions to occur. If you don't have calcium, no contraction is going to happen here, as we'll see. Okay. You can kind of divvy up different areas of the muscle into these motor units, where basically you're going to find that a single motor neuron can kind of innervate different fibers here. So imagine we're going to look at the spinal cord and how it actually coordinates muscle movement a little bit later. But if you were to look at one of these anterior horn actual motor neurons here, notice you can have, say, two different neurons that are going to be kind of firing off, and notice how it's innervating different muscle fibers. That's going to be important because this actually kind of dictates how fine a control, or maybe not fine as the case may be, you can have of that muscle. So for instance, do you have finer control of, say, your quadricep or, say, of your fingers? Probably the fingers, right? So again, that's very important because we like to be able to do very delicate things with our fingers. The quadriceps, not really. We just need to make sure we can get up and walk around and jump and things like that. So that's going to be really important because this will help to show how fine of a gradation we can actually get with our muscle control there. Basically, if you have fewer fibers per motor unit, excuse me. Basically, if you only have like say 2 to 3 fibers being innervated by one single neuron, that allows for very fine control. Very small amounts of muscle fibers can be innervated and activated at any given time there, right? And again, you're going to find you can have lots of different neurons kind of helping to innervate, and there's a lot of overlap of motor units, and that's good because that can make it so you can have very fine control. Say if I need to do something like suture a patient, or if I need to do something a little bit more forceful, I can do that. Or if I need to like really shake someone's hand and really do a good power play there, like I can do that too, right? And it's going to be based on how many of these motor units I'm actually recruiting, right? So again, the more these motor units I'm recruiting at one time, the stronger the force of contraction is going to be. More fibers are going to be squeezing at the same time, essentially, right? So that's what I mentioned when I say graded contractions there. Based on more motor units being activated, the stronger the contraction is going to be in those cases, right? So again, if I were just to activate this one particular neuron here, I get one set of contraction, kind of one set of force. However, if I did both of these at the same time, the total actual force here on the muscle is going to be even higher, right? Because again, more fibers are squeezing at the same time. Okay, so let's look at the neuromuscular junction. So this is where actually the signals heading from the spinal cord, maybe coming from the CNS or maybe other interneurons in the spinal cord, are going to basically interface with the muscle itself to cause an activation. So has everyone ever heard of an action potential before? We're going to talk about those again. So just hopefully you have kept the general mechanics of an action potential in the back of your mind, because this will come up again here, okay? So basically, what you're going to notice is there's going to be a neuron that's going to be interfacing with the muscle here. This is called the neuromuscular junction, right? So again, between the neuro and the muscular, we have the junction here. That's where the actual communication is going to be happening. Now, one of the things to note here is that the neurotransmitter that will predominantly stimulate skeletal muscle is going to be acetylcholine. Our friend acetylcholine. What does acetylcholine normally interact with? What type of receptors? Muscarinic. This is not the case here, though, right? So we're not talking about the parasympathetic nervous system. This is going to be with neuromuscular activity. You're going to find that these are nicotinic receptors, right? And we know what the first substance we found was that interacted with nicotinic receptors. Absolutely, right? So again, the names kind of make sense from that standpoint. But nicotine or nicotinic receptors are the main thing that's going to be interacting with acetylcholine here to actually cause depolarization of the skeletal muscle to actually cause the movement to occur, okay? All right, so basically the general mechanism is going to happen here. Again, we'll kind of go over these in more detail, so I'm not just going to read it off to you. But basically what you're going to find is that as an action potential comes along the motor nerve, it's going to find its ending there on the muscle fiber itself, right? So this is where it actually gets to the neuromuscular junction itself. At each of the ending, you're going to find that it will secrete a small amount of acetylcholine, okay? At this point, that acetylcholine is going to interact with those nicotinic receptors, and we're going to have these cation channels. When I say cation channels, what does that mean? Basically means when I activate these, it's going to allow for cations to flow into the muscle. And what's our primary cation that flows into, say it's in a higher proportion in the extracellular space? Sodium, right? Sodium is going to be our main thing here. So basically, you're going to have these acetylcholine-gated channels, which just means that they are activated by acetylcholine. They are going to open up and allow cations to flow through. And again, sodium is going to want to go along its concentration gradient, and that's going to be the predominant ions going to flow into these channels here. Okay. So basically, once we have this sodium is going to diffuse into the interior, this is going to cause the actual depolarization to happen. That depolarization wave that can then travel and excite the entire muscle fiber that it's interfacing with, right? And so we'll look at the action potential, how it actually gets generated there in just a second. But we're going to find that sodium influx is going to be the primary thing that starts the depolarization. However, is sodium what causes the contraction of the muscle? Already alluded to, calcium is going to be the big thing that gets involved. Okay, so the action potential travels along the muscle fiber, right? It's kind of depolarizing the muscle membrane as it goes along. And then by doing that, you're actually going to find that this is going to allow the sarcoplasmic reticulum to actually open up and allow for calcium to flow from its very high concentration in the sarcoplasmic reticulum out. And then that's where we're going to actually find that interface between actin and myosin occurring there. I'll go over more of that detail in just a moment here. But basically, you have to have calcium here. Calcium is actually what causes the contraction to occur. And then do we want to keep that calcium out forever? Typically, no, right? Typically, you want to have a recycling of that calcium, so that way you don't just have a contraction in the muscle and say it's contracted forever. That's not really all that useful. We need that to be able to relax again. So you're going to find that sarcoplasmic reticulum has active pumps that will pump calcium against its concentration gradient back into the sarcoplasmic reticulum. Again, does that process require energy? Yeah, it's an active process, right? It's going to take ATP to go against the concentration gradient. So you're going to have those on the sarcoplasmic reticulum, pump calcium back in, and then you basically have a reset of the whole system there, okay? Some pictures that will actually show that in a little bit more detail here. So again, let's imagine we're having our neuromuscular junction here. That we're actually going to have the nerve signal transmit down. And you're going to find as well these neurons are going to be kind of not just at the surface of the muscle itself, but it can be kind of interwoven in between, as you'll see there. So you imagine looking at, say, a cross section of the muscle, you can find these nerve terminals are going to be kind of located within the muscle itself, right? So that when we have a depolarization kind of travel out in either direction there. So you can find that these branches can happen several times, and maybe just a few branches, say only like, say 3 times versus several hundred times, right? So that way you can innervate a wide amount of that muscle all at one time. So that way when you have a muscle, an action potential come along, the whole muscle contracts all at once, essentially, right? You want it to be sort of a simultaneous sort of action there, okay? The other big thing here is you notice these kind of clefts here. Notice it's going to be going in, and this whole thing here is going to be kind of lined with acetylcholine gated channels here, and that's important because by having that increase in surface area, just means that a very small amount of acetylcholine is going to mean that to be able to activate and cause the sodium channels to open up to cause a depolarization. Okay, we'll look at some disease states where actually you can modify the number of those receptors and cause some issues there, right? Okay, so looking at the secretion of acetylcholine itself, as we know, acetylcholine is just a combination of acetyl-CoA plus choline that get put together, essentially, and they do get metabolized. Once it's kind of had this activity on the muscle, you're going to find that acetylcholine doesn't stick around forever. It has to be metabolized. And so this is where we have something called acetylcholinesterase. We'll break it down, and then we can actually recycle that choline, put it back with another acetyl-CoA, and then we have a new molecule of acetylcholine to be recycled there, right? Usually the neurons like to be pretty efficient, so whatever they can recycle from metabolic byproducts are going to do so, right? Or if they can recycle the whole neurotransmitter, it's going to try to do that as well. Think about things like serotonin reuptake. Like we like to be as efficient as possible. That's one way we can do that. Anyway, once we have the nerve impulse actually travel down the neuron, that's going to cause a depolarization of that neuron, and that will then stimulate acetylcholine release. You can find they actually have calcium channels here. That calcium normally is going to come in and allow for these, basically for these vesicles to undergo exocytosis, right? So you see these vesicles containing acetylcholine. That will cause exocytosis, and that can interact with acetylcholine receptors, okay? Once these channels are open, sodium is going to allow it to flow in, and then as that goes down, these voltage-activated channels are what's going to be the main thing driving the depolarization, right? So acetylcholine is only responsible for the initiating the signal, but once that sodium comes in, and once you hit that certain threshold to cause a depolarization, the sodium channels kind of take over, okay? These are voltage-activated, meaning once they hit a certain depolarization, once they get to a certain potential, that's when they open up and allow for that continued propagation, okay? Okay, so again, acetylcholine is binding on those nicotinic receptors. Is going to open up the channels, allow sodium to flow in, and then eventually they will close back off, and then you can have a resetting of the whole cycle here. Now you can actually have too much activation of these channels here, and you can actually wear these channels out over time. So imagine what would happen, say if I had something that kind of kept binding to this channel and just kept it open for long periods of time. What do you think would happen to the muscle? Stay contracted at first, but then if it has no signal to actually cause a depolarization, what can happen? Can actually end up developing paralysis. So this is actually, when you talk about paralytics, this is the main way we cause paralysis in patients. When do you want to paralyze your patients? And they're like bad-mouthing you or something? Surgery is a big one, right? Or before I'm intubating a patient, I want to kind of relax all the muscles within the airway, so that way I can actually get an ET tube down their throat. That's one thing I can do. But surgery is another big one, right? So we like to paralyze these patients in order to make sure that they're not going to be fighting us, essentially. It's actually one of the ways we can do that, where you actually have too much activation, you actually fatigue these channels here. So even if your neurons are releasing acetylcholine, the channels there, they're so kind of overworn out from having too much activation, they actually don't cause any, nothing happens essentially, right? So you have this kind of flaccid paralysis that can develop there. And so there's actually a drug called succinylcholine. Any of my EMS people heard of succinylcholine before? Perhaps. Well, this is a drug we use very frequently to cause paralysis for intubation, as the case may be. Basically, it'll come along, activate the channel, open it up, and then eventually desensitize it, leading to paralysis. Okay. And again, looking at, say, the electric potential here, imagine, you can also have things that can block the channel itself. So imagine if I had something that sat on that nicotinic channel and blocked it from occurring. What else do you think would happen? That could also lead to paralysis, right? So you could have kind of either end of it, where basically you could block the receptor, prevent acetylcholine from activating it, causing paralysis, or I could basically wear out the receptor and make it desensitive, or desensitize it to acetylcholine, so that way it would also lead to paralysis. Kind of two different ways to do the same thing here. But imagine you have, say, a normal action potential occurring here in B. Notice here you have to have that certain threshold before you actually have the depolarization occur. If I block the channel, you may have a little bit of a rise in potential here, but not enough to actually cause that threshold to be met. No action potential occurs here. Other situation could arise though, where maybe you're blocking acetylcholine from being released in the first place. So this is actually where botulinum toxin, otherwise known as Botox, actually works here, right? So say if you were to inject it into the forehead, you can have patients look like really surprised to see you all the time, right? Or you have cases where patients actually have increased spasticity. You'd be surprised how many kids we actually use Botox in, not because they have like crow's feet or anything, but because of the fact that they have things like cerebral palsy or they have GI disorders or things like that, where you can actually inject Botox into the muscle itself, prevent release of acetylcholine, and cause a paralysis for those muscles. So actually, you have kids who have like really bad contractures, you can actually relax those muscles and allow them to have a little bit of relief from all that pain associated with that, and have a little bit more function there, right? So different ways to kind of get the same thing, but you need to have acetylcholine interacting with those receptors in order to cause a depolarization to occur. Okay. Here's another condition called myasthenia gravis. This is an autoimmune condition, so I'm sure Dr. O could probably tell you much more about it than I can, but basically what this actually does is causes a blockade of acetylcholine transmission, right? So one of the big things you'll see with these patients is actually they'll develop weakness, they may have a difficulty speaking. One of the big things you'll see here is this ptosis, where basically they'll have kind of their eyelids start to droop a little bit. Could be related back to the fact that by having this autoimmune condition, basically you're having all these antibodies blocking the acetylcholine receptors, it prevents this transmission from happening normally, right? So you have fewer receptors to interact with acetylcholine, thus less transmission happens, thus you can't contract the muscles appropriately. So that's one case where you can actually have some issues there. Now, one way to actually to test for this and actually to fix it, we'll actually give them an acetylcholinesterase inhibitor, right? So I'll actually give them something that will block the activities of that enzyme. And what do you think happens to acetylcholine levels in those cases? Should go up, right? Because the metabolizing enzyme has been inhibited. Now those levels of acetylcholine will go up. And actually, if you give the patients with myasthenia gravis acetylcholinesterase inhibitor, you should see return to somewhat normal function for them. You should start to see their eyelids start to peak back up. You should start to see they're talking better. Muscle strength is improved because you have more acetylcholine to interact with those receptors. Basically, it's more of a kind of competitive sort of effect there. But if you see that, then that is actually a diagnosis. That will tell you, yes, this patient does have myasthenia gravis because they had a positive, we call it a tensilon test or an etrophonium test. It's the substance we'll give them to do that. But again, just know that if you don't have enough acetylcholine interacting with these receptors, you're going to have muscle weakness, you're going to have paralysis potentially develop, right? Again, usually we'll treat those patients, either we'll give them things like anti-inflammatories to try to prevent the antibodies from interacting with those receptors, or we'll give them things to try to increase acetylcholine levels, right? So there's just two examples there. And again, I'm not going to ask you specific drugs on this test by any means. When we talk about them in Pharm, this will come back up, but we're not going to talk about them, or at least if I bring up a drug on the test, I'll tell you specifically what it does. I'll say, hey, this is an acetylcholinesterase inhibitor. What effects do you think this would have on neuromuscular function, right? Those are things I might ask. Okay. So anyways, so let's say we have this action potential. It's going to be spreading along. The other big thing that helps for these really kind of deep muscle fibers to all work in concert with one another are going to be with these T tubules, right? So we call them T tubules because they're transverse tubules. So you'll see that you can actually have an action potential travel along the membrane, and then it'll go down these transverse tubules here and actually allow for this propagation very deep down into the muscle fiber itself, or into the muscle tissue. That's going to be good. And we'll also see another section here. This is what's going to help with the release of calcium from the sarcoplasmic reticulum. We call this excitation contraction coupling. When this occurs here, and I'll show you a picture of what that calcium release looks like in just a moment here, and they're happening through these dihydropyridine receptors. Okay, they're also linked to what we call these ryanodine receptors, and those actually, this is located on the sarcoplasmic reticulum itself. We'll talk about that in a moment. But anyway, so basically, once you have a release of calcium from the sarcoplasmic reticulum, that's where you can actually see the contraction occur, and we'll go over the mechanics of that in just a few minutes. Okay, so looking at the actual calcium function, imagine you have a wave of depolarization coming along here. You're going to find that this will then cause these channels to open up, these DHP channels. These are going to open up and then will cause activation of the ryanodine receptors. This is then going to cause the calcium channels to open up and then leave and then cause the actual contraction to occur. Okay, when you have repolarization occur, you're going to find this will cause deactivation of the ryanodine receptors, and then you're going to have the calcium being pumped back into the sarcoplasmic reticulum, and then you're kind of back to normal. Okay. Another way of looking at this would be, here's your T tubule right here. Imagine if you had the action potential traveling along. This is eventually going to release calcium from the sarcoplasmic reticulum, but that's going to cause a contraction, and then eventually it's going to be shuttled back into the sarcoplasmic reticulum for relaxation, and then for eventual re-release. Okay. So what do you think would happen if, say, there's some sort of aberration here, and you had this channel never close off? That ryanodine receptor just kept releasing calcium. Constant contraction. Okay, anyone know what that's otherwise termed? It's not a seizure necessarily, right? So sometimes we'll see with abnormal firing of the CNS that can lead to things like tonic-clonic seizures and muscle contractions. We'll look at that a little bit later on, but this is a different condition here. This is specifically a muscle issue, not necessarily a neuron issue, right? Yeah, so basically you can see this tetany here, where you basically have no relaxation of the muscle whatsoever. And so when you have this muscle that's being overactivated, what do you think is generated there? Lactic acid, good. So you maybe get acidotic. What else is happening? What else is a byproduct of all this trying to utilize all this ATP and producing ATP? What happens when you work out really hard? You get cold or hot? You get really hot, right? So you're building up a lot of heat. You're going to have a lot of acid start to develop here, develop a lot of CO2 based on trying to utilize that ATP to make sure those muscles are staying contracted, because as long as the calcium in there, you're going to find the muscle stays contracted. This is actually a condition called malignant hyperthermia. So if you ever worked with like surgery or you work in the ER, you may have heard of malignant hyperthermia. Certain patients are going to have a mutation in this ryanodine receptor that when they have exposure to certain substances, particularly one called succinylcholine, as I mentioned, is a paralytic agent, or in surgery, there's some inhaled anesthetics, something to try to keep you asleep, that will actually cause the ryanodine receptor to open up, allow all this calcium to flow out, and then you have these patients who are, these muscles are just become very, very contracted. They'll start to develop a ton of heat. They get very acidotic and can be rapidly fatal if you can't actually counteract that. So if you ever hear malignant hyperthermia, that's what we're talking about. And it has to do with the fact that this ryanodine receptor just won't let that calcium channel close, and you have all this calcium spilling out, causing too much contraction. Kind of make sense? So again, it's important to have that regulation there, because otherwise you're going to find that you're going to have either no contraction occurs because you don't have enough calcium, or you have too much calcium and too much contraction happens there. Okay, let's go ahead and do a 10-minute break now. We'll come back and then talk about the actual mechanics of contraction. All right, I repeated this slide here just so I can readdress something. Any questions, though? Yes. Basically, it's going to be located along that T-tubule, right? Anyone else? Okay, I repeated the slide here just to kind of illustrate a point. I thought of a better way to explain it, trying to explain it to one of your cohort. But basically, when you're thinking about the acetylcholine versus the acetylcholine activated sodium influx versus the actual sodium, I'm trying to think of voltage gated sodium channels, kind of the difference between the two. You can imagine the acetylcholine receptors opening up those sodium channels to try to increase the polarization here, to try to get up to that threshold, right? At this point, this is where you're going to find those voltage gated channels are actually going to open up, and this is what causes that rapid depolarization, okay? So again, the acetylcholine only gets you part way, only gets you to that depolarization point, and then it's voltage gated sodium channels opening up, just like you would see, like say in the heart or in other places, right? They're actually causing the actual muscle contraction itself. Make sense? Okay. Anyway, so going back to the actual mechanics of contraction itself, remember we're kind of breaking things down into the individual sarcomeres. Remember here that the sarcomere is basically delineated by what, between what two lines? Yeah, between two Z discs, right? That's where our actin molecules are going to be kind of anchored to. And they're going to find that the myosin is going to be right here in the middle. Kind of the M line is going to be the center here. But again, we're looking from Z disc to Z disc. So again, we're talking about actual contraction. We're just going to look at this based on one sarcomere at a time for this purpose here. Okay, so again, as I mentioned, the I bands are only going to be the part where you have the thin actin filaments by itself. That's kind of the light bands you're going to see there. With the A bands, this is where we're going to have some overlapping occur. And you want to have some overlap because this is what's going to allow for the actual contraction to happen in the first place. If the actin and the myosin were never close enough to actually meet up at all, you wouldn't really ever have a contraction there. And so that kind of goes back to, we'll look at the actual force of contraction that can be generated based on muscle length. We're going to find there's kind of a prime distance, or kind of sort of prime length that the muscle is going to work best. If you go too far in either direction, either too short or too long, you're going to find that's going to kind of interrupt how strong of a contraction we'll have. So we'll look at that in a moment. So anyway, so the H bands, or the H zone, is basically going to be the center of the A band, and this is where we're going to have no thin filament overlap whatsoever. So if we were to look at this H zone here, is basically where there's going to be no overlap between the actin and the myosin. Okay. So again, basically there's no overlap happening there. This is where actually the contraction, you're going to find that the Z discs are typically going to be moving in towards that H band as the contraction actually occurs. That's where a movement of the actin along the myosin, as we'll see in a moment here. Okay. Okay, so again, going down to the individual sarcomere here, again, this is that basic subunit of the striatum muscles where the actual contraction occurs here. There's multiple sarcomeres are going to make up one myofibril. Again, they're all going to be kind of fused into one length there. And again, we're talking from one Z line to the next Z line. Okay, so again, Z bands right here. Again, from either end, we just have the actin filament. This is where it's going to be known as the I band. We'll have the H zone here where there's no overlap. This is the A band itself, right? This is where the dark area we're having overlap between the actin and the myosin actually occurring, right? And again, movement should be heading in this direction or in this direction, right? So it should all be heading towards that H zone there as you actually have the contraction occur, right? Okay. You can see here when you're actually looking at, say, a relaxed sarcomere versus when it actually is going to be contracted, what do you kind of notice? There's a lot more overlap that's actually occurring here, right? So again, as it's contracting together, you're going to notice that you're going to have the Z lines are going to be pulling together. It's going to become much shorter. This is when you actually have the muscle contraction itself here, okay? Now again, can it contract any further than this? You can. You'll actually see that's going to lead to decreased strength. There's going to be kind of an optimal zone where the muscles are going to be making the most force here. But again, notice your H zone basically kind of disappears at this point because again, you're going to have a good overlap between the actin and the myosin along the entire length of the myosin itself. Okay, so again, the H band's going to basically disappear, or just shorten or disappear. Depends on how much of a contraction you're actually shooting for, depending on what your need is. Yes, sir.
Question. So, what is the physiologic reasoning behind like fully extending your muscle when you're like exercising whatever like body group? You know, 'cause they always say, you know, when you're doing pull-ups, go all the way down because I don't know, you're gonna have more muscular hypertrophy. Like, which particular segment of this? The thick and thin filaments is, you know.
So imagine when you have, yeah, I kind of get what you're saying there. So, you know, so imagine you have the entire muscle, right? So again, these are basically just a long line of a ton of different sarcomeres all lined up right next to each other, right? So again, you're going to find that as you have the muscle being kind of fully elongated, right, that's going to require the most force to actually cause that to occur there, right? You're going to have to recruit the most amount of motor units and the most number of sarcomeres together to cause the actual contraction to get from, say, a fully extended position to a fully contracted one, right? Especially if you're under load or under gravity or whatever the case may be, if you're, say, you're doing a pull-up, right? So again, by doing that, you're kind of working the entire muscle rather than, you know, I always like the people that I do, like, you know, pull-ups and they only go like, you know, an inch either direction, like, yeah, 100 of these, knock them out. Versus if you go to fully extended versus fully all the way back up, you're going to find that that you get a lot more of the muscle actually being worked there, right? Or like the CrossFitters are like using all momentum just to like knock out like 1,000 of the right. So again, if you're using momentum to get movement, you don't actually have as much force on the muscle itself, right? So again, the more workload you're putting on there, we'll talk about work in a second. The more ATP you're having to use, the more stress you're putting in there, the more hypertrophy that presumably should develop in those cases, right? And again, this is not the class to learn how to get swole. That's my seminar I run afterwards. We'll talk about that later. That's my other YouTube channel you guys don't know about. Actually, I was working yesterday at the hospital, and one of my technicians has been like working out a ton. He's getting like super buff, and I was like, listen, I'm gonna go check that vault. If we're missing testosterone or growth hormone, I know exactly where it went. He's like, don't look, just don't look. Okay. Anyway, so let's look at the individual fibers themselves. We're going to look at the myofilaments here. The myosin is that thick filament we're going to talk about first. Again, this is where basically you won't find the myosin itself is moving too much. It's really the actin is going to be moving along the myosin, as we'll see here in a moment. But basically you're going to find it's made of several chains. We're going to have both heavy chains and these sort of light chains here. The heads here are what's actually going to cause the movement. So again, if you're looking at the head here, this is basically the same sort of head in a different kind of pictorial representation. This is what's going to cause the actual movement of the actin along the myosin. We're going to find there's a binding that occurs there between the two, and it's going to cause it to move forward towards that H zone, right? So again, on either end of it, it's going to cause movement of the actin towards the center there to try to shorten up the sarcomere, try to get rid of that H zone, or at least make it shorter, the case may be, right? Now, one important thing to note here is that the actual myosin head itself has an ATPase activity, right? So when I say ATPase, what does that do? It aces ATP. Exactly right. So it converts it into ADP plus phosphate, right? Exactly. ATP is adenosine triphosphate. We turn it to ADP plus an extra phosphate. That's an important concept to get down because that's going to is important to make sure we have good binding of the myosin head to the actin and also causing it to dissociate. So we're going to look at that in just a moment here. But just remember that myosin has the ATPase activity. Yes, sir.
Can you repeat what ATPase does one more time?
Yeah, ATPase is going to cleave ATP and turn it into ADP plus a phosphate, right? Okay, so next we're going to look at the actin. This is actually an electron microscope view of some actin filaments here. Just kidding. I always thought they kind of looked like churros. I thought it was kind of funny, but like, wow, those things have really high detail there, and it looks like they're in a Mexican restaurant. Anyway, So typically what you're going to find is that the actin itself, again, this is the thin sort of portion here, are going to be this kind of this tight helical structure of a few different proteins here. So we're going to see there's going to be the actual F-actin, where you're going to find this is going to be kind of a double strand. It's kind of two light pink sort of lines here. This is actually going to be the F-actin itself. There's going to be a tropomyosin, which is going to be this dark line here, and then there's going to be a troponin complex. I'll talk about how all these are going to be functioning here in just a moment. Basically, the double-stranded F-actin, this is where it actually contains the active sites for the actin itself, right? So you're actually going to find these active sites are made up of ADP molecules. Okay, so keep that in mind. Again, we're already looking at ATP, how this is going to be integrating together, but the active sites are just ADP molecules. Okay, so again, if you add a phosphate to that, you get ATP, but these are not ATP, these are ADP. Okay, this is where you're going to actually find the cross binding here. So again, normally when you have a relaxed muscle or a relaxed sarcomere, you're going to find that these are going to be covered up. These active sites are going to be inactive because they're going to be covered up by this tropomyosin, this kind of dark colored strands here. Basically, when they are covering up the active sites, they prevent unnecessary contraction from occurring. Okay. Now the question is, well, how do you get that tropomyosin out of the way so that it can actually interact with the active sites? And that's where troponin is actually going to be coming into play here. So troponin itself is made up of kind of three different proteins here. We're going to see there's troponin I, T, and C. Troponin I is going to be having the strong affinity for the actin itself. Okay. Troponin T is what's going to bind to the tropomyosin. So the tropomyosin is what's already kind of covering up the active sites. And then troponin C is going to have the affinity for calcium. So this is where calcium actually comes into play. This is where calcium is going to come out of the sarcoplasmic reticulum. This is going to bind to that troponin C, and it's going to cause a conformational change such that the tropomyosin is going to uncover the active sites. Okay, so calcium comes in, interacts with troponin C. That's going to cause the tropomyosin to uncover those ADP active sites. And this is what's going to initiate the contraction with the myosin. Everyone with me so far? And then when you get rid of the calcium, what happens? It's going to go back to its original conformation. The tropomyosin then covers up the ADP, and that prevents it from interacting with the myosin itself. Okay. Yeah, so if you were to have, say your body wanted to initiate a contraction, I send a nerve impulse down from the spinal cord, it interacts with the neuromuscular junction, releasing acetylcholine to cause the action potential to generate. Once that calcium is being released from the sarcoplasmic reticulum based on that wave of depolarization, that calcium is going to interact with troponin C. That's going to cause a conformational change in the actin such that you're going to have the tropomyosin uncover the ADP active sites. This is then going to allow for that the interaction between actin and myosin that causes the contraction. When you're done, you shuttle the calcium back into the sarcoplasmic reticulum. The conformational change will reverse itself, such that tropomyosin is now covering up those ADP active sites. Okay.
Where did I come into play?
Troponin I is what's going to be binding to the actin. So again, you notice that each one of these is binding to a specific portion of the protein, right? So again, this one's going to be binding to the actin. This binds to the tropomyosin. So again, you need to have them there so that we can actually cause a conformational shift there. Okay. Okay. All right. So basically, the theory for contractions we're going to be working off of here, because again, all things in science are really theories until proven otherwise. We're going to call this the walk-along theory of contraction. Okay. Basically, what this means. Again, right here, you're going to have your myosin filament. You're going to have your actin. Notice the active sites are here. And again, the active sites are what? ADP, right? And we already said that the actual heads of the myosin molecule stuff has an ATPase enzyme activity. So we're going to look at that in a moment. Okay. Basically, what's going to happen here is you're going to have the actin. Once it's activated by calcium, you're going to uncover the active sites. So ADP is going to be exposed now and can interact with the myosin. Myosin heads are going to tilt at the hinge. So you're going to notice how it has a nice kind of hinge here. This is going to cause it to hinge forward and move the actin towards that H zone, right, towards the middle of the myofibril, or middle of the myosin there, right? So your movement's going to happen in this direction here as you have what we call the power stroke. So again, it's not like your Ford engine or whatever happens to be. I think that's Ford, right? Maybe. I don't know. Cummins stroke? No, power stroke. Okay. I'm just kidding. All you truck guys out there got that one. Anyway, so again, we're going to have this forward movement of the myosin heads. This is what's going to move the actin. We're going to find there's going to be a binding. I'm going to go into detail on what happens there in a second. It's going to move that forward towards the middle of the myosin, right? So you're going to find that H zone is going to shorten up as this occurs here. Now, again, are these all happening at the same time? Not really. You can find that as one binds and maybe another one binds a split second later, and so you're going to have sort of a concerted effort where they're going to have many of them binding and unbinding all at different times, so that we get a nice smooth sort of contraction. We kind of look at it over the whole sarcomere. Okay. But typically, you're going to find that they operate independently. And then the more active, the more of them you have going at one time, the greater the contraction force is going to be, right? So for instance, if I have more ATP available, maybe that makes this process work, that can make it work more forcefully. If I have more calcium around to uncover more of those active sites, that will also make it work more effectively as well, right? So the more of them that are active, the greater the force of contraction, the stronger it is. Okay, so let's look at this. Again, I'm going to kind of walk through this. There's some good pictorial examples in a second, but I kind of write it out here so that way it makes it a little bit more clear and we can kind of talk through each of the steps. Okay, so let's talk about before the contraction actually occurs here, right? So again, we have the actin, we have the myosin, they're separate. Remember that right now the ADP active sites on the actin are covered up because there's no calcium to bind with that troponin C to cause that conformational shift, right? So basically, before the contraction occurs here, you're going to find the heads of the cross bridges, right, are actually going to bind with ATP. So the myosin heads themselves are going to bind to ATP. We're going to say that the ATPase activity of that myosin head is then going to cleave it into ADP and phosphate, and that stays bound onto that myosin head for the time being. Okay, this is what puts it into the cocked position where it's kind of ready to go. As soon as that the actin is exposed, the ADP site's exposed, that's when the actual movement can occur here. But right now it's kind of in cocked and loaded, ready sort of state to go as soon as those ADP sites are available. Okay, when troponin and the tropomyosin complex bind to calcium, this is where you're actually going to find the ADP sites are going to be exposed. And now what you're going to find is that the actual bond here is going to occur between the actin and the actual myosin head itself, right? You're going to find that that phosphate group on the myosin head that's just sitting there is going to be attracted to that ADP. It's going to want to travel to it, and that's what's actually going to cause the binding and is going to cause that actin to move towards the middle of the myosin, okay? Again, I'll show you a picture of this in a second to make it more clear, but I just wanted to kind of put it in a sort of state here. So anyway, and when that actually occurs there, when the actual energy happens, it's like basically like kind of letting go of, say, I said it's in kind of the cocked position. That's when it's going to be ready to go. As soon as it has that active site to bind to, it's going to release that energy and then move it forward. Okay. So again, once the head of it tilts, it's then going to release the ADP and the phosphate that were previously attached to it. So now, once the actual movement has occurred, this is where ADP and phosphate are going to release from the head itself, and this allows for a new ATP to bind to it. Okay, so now ATP is going to bind to that again. This is going to allow it to detach from the actin. It's going to move it back down to the original state. Now the ATPase enzyme is going to convert it back to ADP in phosphate group, and now it's ready and then again back in that kind of cocked original state. Again, the picture will make this more clear in just a moment. Okay, so imagine here we have the inactive sort of state here. Imagine again we have our actin filaments here. We're going to have our myosin here. Notice that in the resting state, this is when it's kind of ready to go, is when it has cleaved that ATP into ADP and phosphate here. Okay. Once calcium comes along and binds to it, you're going to cause those active sites to be uncovered, and this is what's going to cause the binding to happen here. And then we actually have the power stroke. This one actually moves the actin this direction. It's going to move it forward. So it's the actual contraction occurring itself. Okay. Once that happens, ADP and phosphate are going to be cleaved off of the myosin head. It's going to leave. And then now we're going to have ATP come along and bind it again, and it's going to reset that, right? It's going to kind of unhinge it and kind of bring it back down. And then you're going to see that the ATPase activity here breaks it down again into ADP and phosphate. So now that you notice where the original binding site was here, before it was over here, now it's kind of moved forward. Now this can then bind again to a new active site and cause further movement to occur. Okay, so imagine having this millions and millions of times along that myosin fibril height. You can get kind of a nice concerted effort to move the actin towards the H zone there. Does that make sense? Okay, everyone with me? Everyone's head spinning maybe? I know it seems really complicated, but it turns out humans are complicated in this case. Okay, so again, looking at the actual tension that can be generated in this contracted muscle, it's important to understand there's kind of a nice Goldilocks kind of zone, kind of a middle area where the length of the sarcomere is going to kind of dictate how much of a force contraction we can get here, right? So again, you're going to find that the maximum tension that can develop in the muscle occurs when you have all of the actin lining up, overlapping with all the myosin. Okay, so once all that occurs, once all that overlap has occurred here, that's when you have the maximum amount of tension can develop there. What you're going to find is if you make it any shorter than that, which is possible, you can make it more short, you'll actually start to crumple the myosin by the Z-disc. So basically it's going to, if you go back to those pictures, you can kind of see what, or actually look right here, you'll see that as you start to make it shorter and shorter, it's going to crumple the myosin there. Now you have less myosin that can actually interact with the actin, and so the actual force of contraction goes down. Okay, so again, looking at these different examples here, you notice here at B and C, so again, if on the y-axis here is where you actually have the actual tension develops, so this is a percentage, and then look at the length of the sarcomere, and again, these are very short, so on the order of micrometers here. you're going to find that during cases of B and C where you have all the actin and the myosin overlapping with one another, this is where you have the most tension being developed in the muscle. Okay, if you go much shorter than that, the Z discs start to crumple the myosin. Thus, you're going to see the actual force is going to go down. It's still some force, but it's not going to be as much as it was. And however, if you have no overlap whatsoever, what do you notice about the tension? Nothing, right? Because again, the sarcomeres are going to be maximally stretched out. There's no overlap, and so in order for any force to be generated, you have to have some overlap to occur there, right? So again, that's why it makes sense if, say, for instance, you're doing a pull-up, if you're going from a dead hang all the way up, like some of the sarcomeres might be too stretched out. Maybe they're not generating a lot of force. That's why usually when you have like a fully extended muscle, it takes more energy to initially get that movement going, and then once you have that kind of that nice zone there where there's enough overlap, that's where the most force is going to be generated. Too much contraction though, too short of a sarcomere, we're going to lose some force there. Okay, makes sense so far? All right. All right, another way to put that, and then again, that was just looking at the individual sarcomere itself. Let's look at a more kind of a muscle-wide sort of phenomenon here. So again, on the y-axis, we're going to have the tension of the muscle, and you're going to notice here the actual length of the muscle itself. So you have kind of the normal length of the muscle versus, say, half normal, say you're already sort of contracted, versus 2 times normal, where say you're stretching out the muscle itself. You're going to see that maximum tension is going to develop when the sarcomeres are kind of at their nice resting kind of normal length there, so around 2 micrometers or so. And then as you're going to notice is you have a stretched muscle, they can't generate as much tension. So for instance, if you're looking here, this is say a normal length sort of muscle here. The difference here between say a relaxed, untensed muscle versus when I actually contract it is a lot greater than the case if I was already stretching out the muscle and there's already some tension there. Again, I'm having less of those sarcomeres actually overlapping. You're going to find that you have less total force that can be generated here. So again, stretch out the muscle too much, you can't generate as much tension. And however, if I were to make it too short, again, then you're going to find lots of tension there as well that can be developed. That makes sense? So again, with all things, there's kind of a middle zone where it's going to be working the best. If you go outside of that in either direction, you're going to find it's less efficient, essentially. Okay, so actually getting into the energetics or so of muscle contraction. So again, what is work? What the definition of work is? Yeah, this class is work, I would imagine. Yeah, just wait till farm. It's going to be working overtime. Right, so where we move heavy things over a distance, right? So again, distance has to be involved, otherwise you're not actually having any work done in this case here. So again, load times the distance that is being moved. So again, kind of going back to basic kind of physics concepts here. But what you're going to see is that most of the energy that gets used in our muscles is predominantly going to be used for that cross-bridge pulling of the actin filaments, which makes sense because again, we see that every time you have one of those power strokes, you're utilizing an ATP, right? And again, once that ADP and phosphate are cleaved from the myosin head, you have to convert that back over into ATP before it can be used again. So again, that's what most of the energy is going to be going into. However, other things that require energy as well. Pumping of the actual calcium ions, right? So getting those back into the sarcoplasmic reticulum takes some energy. And then our good friend, the sodium potassium pump, is also going to take some energy. And what does that help us to do in the muscle, do you think? Resting membrane potential. Remember, just like it does in the heart, just like it does in the neurons, same thing's going to be happening here, right? And we'll talk about the action potentials a little bit later on, but again, same thing's happening here as far as the sodium potassium pump. Okay, so 3 main sources of energy that you're going to be finding within the muscle itself. Again, these can all be used to actually form the ATP because again, this is the normal currents that we use for energy here. So there's a couple ones. So there's phosphocreatine. This is going to be containing really kind of a high energy phosphate bond, which you can donate in order to make ATP there. Basically, it's going to donate phosphate to ADP itself to form a very quick, sort of ready form of ATP very quickly there, right? Basically, it utilizes an enzyme called creatine phosphokinase, or CPK. This is actually an enzyme we can measure in the blood of someone who actually is having muscle breakdowns. So if like rhabdomyolysis, we can measure CPK levels and actually tell us how much breakdown is actually occurring there. Now this is good. It is able to generate energy in ATP, but it's only good for a really short burst, right? So very short bursts of quick energy, quick maximal contraction, about 5 to 8 seconds or so. Okay. Now again, when I'm trying to run a marathon, does it only last 5 to 8 seconds? No, so I'm going to need some alternative ways to get energy, right? So again, it's only good for kind of quick bursts for maximal contraction, okay? The next thing we can do, we know glycogen is also stored in the muscles, just like it's stored in the liver. You have some of the muscles there, and that's also going to be utilized for energy. Undergoing glycolysis, we can go ahead and help to reconstitute some of that phosphocreatine, which can help us to make more ATP. And this is good for more anaerobic sort of exercise, right? Because this is going to be occurring in the absence of oxygen, right? So again, this is not the most efficient way to do things, but this is where we can actually have some additional energy being produced. you're going to find it's much more rapid than if we're actually form ATP from, say, ingested nutrients, as you would have through normal oxidative metabolism. It's good for about a minute or so of maximally sustained contraction, right? So again, imagine if I'm trying to like do, say, a deadlift or something off of the floor. Again, initially, that initial burst of energy is going to be using phosphocreatine, and then for continued movement, we're going to have to require that glycolysis of the glycogen, right? And again, you can wear out these after a period of time, and then you're going to see muscle fatigue is going to start to develop, as we'll see a little bit later on. Now, the other 95% of the energy we get out of the muscle is going to be with oxidative metabolism, just like we've covered before, right? So again, this is what requires oxygen, is what's going to help to develop that ATP like we were used to seeing before. And again, the most efficient way to produce ATP is going to be with this oxidative metabolism. Now, is our system overall very efficient? Not really. You're going to find that we're losing a lot of this energy is going to be lost as heat, which is why you get very hot when you're exercising vigorously, because a lot of that extra energy gets lost there. Okay. Okay. So let's look at some characteristics of muscle contraction. So looking at this, when I say isotonic versus isometric, does anyone know what those mean? So iso just means basically staying the same. So again, if we're looking at isotonic, we're going to see the isotone. The tone's not going to be changing throughout the muscle, okay? I say isometric, what does that mean? The length of the thing is the metric, the actual length of something is not going to be changing here. So that's important. We're looking at this in just a moment here. So isotonic contraction, this is where the muscle fibers are going to be shortening when actual tension is produced. So again, we're signaling through action potentials to go ahead and cause a contraction to happen here. Once that contraction is greater than the force of the load that is being applied to the muscle, this is when you actually have the movement occur here. Okay. So again, you have to generate enough force, and this was actually going to cause the contraction. So what you notice why it's isotonic is because the actual tone in the muscle, the actual force is going to be contracting, is going to be consistent all the way throughout. Okay, so the actual contraction itself is consistent. However, movement is occurring here, right? It's going to be in direct opposition when we talk about isometric in just a second here. Okay, now there's going to be kind of two movements that can happen. There's going to be concentric contraction, right? So this is when the actual muscle fiber is shortening when the force is greater than the load, and then we have eccentric contraction, and the muscle is going to be lengthening. But again, it's not just like, there's kind of two types of people at the gym, right? There's people who are, say they do a deadlift, and you can either set it back down very nicely, you have a nice eccentric sort of contraction, right? Or what can you do? You can throw it down, you can yell really loud and make yourself look super cool. I will not tell you which one of those I am, but that's why I have a home gym in my garage where people don't really bother me. But anyway, so again, the eccentric contraction is where, again, you're still having force being produced. There's still a contraction, but it's much slower, right? So again, it's going to be kind of, you're actually lengthening the muscle, but it's not like you're just letting off all tone altogether. There's still some amount of contraction happening there. Okay, make sense? Okay, on the other hand, you have isometric contraction. So this is where the actual muscles don't change length at all. However, you may find that the actual tone or the actual amount of contraction can change here, right? So again, looking at this, if you were to see that there's no actual difference in the length of the muscle itself, however, the actual pressure is going to be generated, the actual tension is going to be changing. Okay, so here's a kind of a low tension sort of state versus when it contracts, we have a high tension sort of state. This is really good, especially for muscles that are, say, like anti-gravity muscles, or things that are keeping us upright. The other day I was actually reading a book about anti-gravity. Couldn't put it down. It's great. Anyway. But you're going to find that some muscles are much better for more isotonic contractions, some are better for more isometric sort of contractions there. So imagine looking at the duration of depolarization, right? So you notice the depolarization itself is pretty quick, right? Action potentials happen almost instantaneously. But when you actually look at the length of time that a muscle stays contracted for, it's going to be directly suited to whatever the muscle is being used for predominantly. So if you imagine here, like the ocular muscles, this is green line here, it's pretty quick. Why do we want the eye muscles to be so quick? Remember, we can fixate on things, right? So remember that all the saccadic movements we talked about and all that. In order to make sure we can maintain focus on something, we have to be able to have very quick movements in order to facilitate that. I don't necessarily have to keep my eyes over here like for an hour. I'd just develop a headache, right? It's not really suited for that. However, if I had something like the soleus, like what does the soleus help me do? Help me stand up right now, right? So again, if that was not working, if that was not well suited to stay contracted for long periods of time in order to help keep myself upright, I would be on the floor right now, and that would be no good. So again, every muscle is going to be best suited to whatever its purpose is intended for, right? Okay, so then getting into the actual muscle fibers themselves, again, there's various types here. There's kind of two main categories you can talk about. It can be the slow twitch and the fast twitch. And there's a good table here in a second. I'll show you. It kind of delineates the differences between the two in a second. Typically, you're going to find the slow twitch fibers, otherwise known as type 1 or red muscle fibers, are going to be slower in in general, and also have kind of a smaller diameter than some of our white muscles or the fast twitch fibers we'll see here in a second. These are good for long-term contractions, right? These are good for helping to keep contraction for a long period of time without really fatiguing. Now, the reason why they're red muscles is because they have a lot of really good blood supply and also have a lot of myoglobin. And myoglobin does what? Binds to oxygen, just like hemoglobin binds to oxygen. Myoglobin is going to be the muscular version of that. It's going to be binding to that oxygen, which means that we have a good blood supply. We have a lot of oxygen being delivered to that tissue there. It's able to undergo a lot of oxidative metabolism, right? So again, this is better for kind of the marathon sort of pace sort of things, or like keeping me upright for 2 hours as I talk to you guys. It's going to be better for those muscles that need to have good amount of blood supply, good amount of oxygen being delivered there, and a lot of myoglobin to hold on to that oxygen to help keep that oxidative metabolism going for long periods of time. Okay, again, found in a lot of postural muscles, right? So everything keeping me upright right now is usually going to be related back to those type 1 slow twitch sort of fibers. Kind of the opposite spectrum there, we're going to have our fast twitch fibers. Typically, these are much larger fibers. These are going to have a faster contraction speed. They also have the highest ATP consumption rates. They're going to blow through things like phosphocreatine very quickly because they're going to be able to generate the fastest contractions, the most force there. However, because of that, they don't have as much ability to undergo oxidative phosphorylation, oxidative metabolism. Thus, they're going to be fatiguing pretty fast. But in order to help counteract that, they're also going to have things like more glycogen stores in order to make sure they have at least some source of energy for something that may last more than 5 to 8 seconds. When they kind of exhaust that phosphocreatine, they at least have something to generate some extra energy. Typically found in a lot stronger muscles. So again, they can generate more tension, say than the type 2A fibers, which we'll look at in just a second, but less tension than the type 1 fibers in general. Okay, so again, kind of shows you the difference between, say, our slow oxidative type or type 1 red slow twitch fibers versus our fast twitch fibers over here, and kind of notice kind of the differences in activity here. So again, the diameter typically smaller for more of your slow twitch sort of fibers here. Don't really care about the Z thickness so much, but notice the glycogen content a lot higher in those fast twitch fibers, right? Because again, they require that to make the kind of maximal contraction very quickly, but again, they get tired out very quickly as well. Resistance to fatigue, much lower in the fast twitch fibers, usually a lot less capillaries, and you would see something like the slow twitch fibers. Myoglobin content is going to be very different. Respiration, what do you notice about the respiration here? And fast twitch fibers, because they are not as reliant on oxidative metabolism and get that really quick squeeze going on, that quick contraction, they're going to be more focusing on more anaerobic metabolism, right? So again, they can, again, that's where you find those stronger muscles. Those are the ones you, when you're working out, you're going to develop things like lactic acid because we're undergoing that anaerobic metabolism. Kind of makes sense, right? Again, oxidative capacity is going to be different, and all of these kind of make sense based on what we talked about already, right? And again, looking at the twitch rate, obviously fastest in the more white muscle fibers of fast glycolytic fibers. Okay. So when you hear people talking about fast twitch versus slow twitch, that's what we're referring to. Okay, so let's go into more detail on the actual motor units here. So we said motor units are going to actually be innervating different numbers of muscle fibers. So again, we can have just a few fibers being innervated by one motor unit, or you can have a large number of fibers being innervated. It just depends on the actual neuron. And again, the smaller the number of the fibers that we're innervating, what does that mean about the control we can have? Much finer control, unless, you know, as opposed to you know, innervating say the entire say quadriceps or something like that, right? You know, fine control would only say 2 to 3 fibers maybe per muscle versus having much higher amounts there. Again, good for graded contractions. So when talking about actually recruiting different motor neurons together, we're going to talk about things like twitch, summation, and then tetanus here, okay? Basically, a twitch is we're going to have just a very quick muscle contraction that occurs here, usually after, say, a single electrical shock or a single action potential. It's going to cause a quick contraction to hit sufficient voltage to cause a depolarization, and then it's done, right? So again, this would be the case where you'd have a single twitch. Notice here you're going to have a single action potential that will cause that to happen, right? So again, you have a very quick depolarization. Calcium gets released from that sarcoplasmic reticulum, causes a contraction, and then calcium is going to get sent back, and then everything resets back to baseline, right? And you can have multiple of those in succession. Now, however, do our muscles normally activate by just causing one twitch at a time? So if I need to like pick up something off the floor, I just have like one single twitch and everything's up, and then it doesn't really work that way, right? So again, we're going to find that you need to recruit those muscles to work together in a lot of cases, and this is where you have summation that occurs. So by having multiple action potentials that are coming along, working very close to one another, and you see here the frequency here is faster. It's again, you have 2 action potentials in quick succession. You're going to see that you have this twitch summation that occurs here. So before that first twitch has enough time to relax the muscle back to baseline, you already have another action potential causing even further contraction to occur. Okay, so as for a stronger contraction, we're having more action potentials. Okay. Okay, so more action potentials means you're going to have more of this, the summation that can occur. It means you're going to have a stronger contraction. Okay, or if I need to keep something contracted for a long period of time, then that's when I have successive actin potentials coming along to make sure that muscle stays contracted at a certain point, right? Especially for like your postural muscles and things like that. So again, by increasing that frequency there, you're going to find that you're going to increase that force of contraction, and this is where it can also lead to tetanization, which I'll show you a picture of in just a moment here, right? Now, typically what you're going to find is that the smaller motor units or the smaller fibers tend to get activated first, followed by the more larger motor units. The larger fibers tend to be a little bit slower to be recruited, which is why I can have very small, fine control, and then as I increase the number of motor units that recruited, they get bigger and bigger and bigger, which can form a stronger contraction. Okay, make sense? So again, it's going to start with the small ones first because they have this, the fastest signals, and then get bigger and bigger and bigger as they go along. Okay, here's another good one to show you here. So again, a single act potential causing a single muscle twitch. If I have two in rapid succession, you can see what this initial twitch would look like if I didn't have another action potential come along to continue that. But again, we're having the summation that can occur here. If I say I have 4 in a row, notice again before you have that original muscle relax back to the baseline, you're going to have more and more action potentials, means more calcium being released, which means more actin and myosin are going to be interacting with one another, cause that walk along sort of phenomenon there, right? And if I have enough of these occur in rapid succession, I can have strong continued contraction of the muscle. This is what we call that tetaning. Okay. When you have that, again, there's kind of like an unfused, where you can kind of see that there's going to be some vacillation between peaks and troughs, versus where you have a fused tetany, which is going to be kind of a strict, steady sort of force of contraction. You're going to find in those cases, that's when you have the calcium just staying out in the sarcoplasm. They're going to be constantly recycled from being shuttled back into the sarcoplasm, or taking them to coming back out to cause that actin and myosin to interact with one another. Okay. All right. There's also this other phenomenon called this TREP phenomenon, or TREP, or I guess du parlez-vous français, maybe you know a little bit better. I think it's a French term. Basically, it's kind of this stepwise approach here, where as you see repeated stimuli, you're going to notice that the force of contraction goes up higher and higher and higher until eventually you're going to get sort of a plateau, where basically you've recruited, all the motor units are going to require recruit at one time, and that's where we're basically going to get that plateau phase that occurs there. Okay. So again, maximum value reached when all muscle fibers are stimulated at the same time. Okay, so when do our muscles get tired? My vocal muscles get tired usually after 2 hours or so, right? What happens there? Well, let's look at it. So one, we're going to find that basically over time the muscles are going to generate less force, and that's mainly going to be related back to less energy in order to actually make that occur, or actually make the ATP form. So again, if we have depleted glycogen stores, that could be one thing. So we kind of burn through all of our glycogen. We can't really use that to form phosphocreatine as quickly. What do we have to rely on? You got to rely on oxidative phosphorylation, right? You have to rely on normal oxidative metabolism. Again, we said that using glycogen to make energy is about 2.5 times faster than having to go through the normal pathway. So again, once we kind of blow through our quick energy reserves, this is where we're going to kind of rely on the more kind of the marathon rates of say oxidative metabolism. And again, that takes time. So that's one reason why we get fatigued. You don't have things like increased accumulation of extracellular vitamin K. See, I almost screwed it up, just like some of you have in your days. But extracellular potassium, right? So again, if I have too much potassium on the outside of the cell, that can tend to make it more difficult for the muscles to contract normally. So that's one thing. If I have reduced sarcoplasmic reticulum calcium, so again, less calcium able to be released, may also lead to less contraction force that can happen there. Things like lactic acid accumulation and lowered pH can also make the muscles work less effectively. And then also lack of ATP. So all these things can kind of work in conjunction, which makes sense over time. If you're vigorously exercising, the muscles are going to blow through quick energy sources, have to go undergo that anaerobic metabolism, generates lactic acid. All these kind of work in concert in order to fatigue the muscle itself. Okay. All right. We also have things like muscle decline with aging. So again, you can find a reduction in the actual muscle mass. Usually things like the type 2 fibers tend to go down over time. Now, a lot of this could be related to several features. So for instance, you have patients as they get older, they have issues like chronic inflammation that can degrade the muscle over time. Things like oxidative stress can also be a factor here. And then also usually older people, are they more active, less active? Less active. So again, it's one of those things, if you don't use it, you lose it. So again, if you don't use your muscles as much, that activity is going to go down. You can see the atrophy that develops there, right? Other things, if you have poor nutrition, if you don't get enough protein intake, that can also lead to muscle wasting. Decreased anabolic hormones, so if you had less testosterone being produced potentially, and then also motor unit denervation could also be an issue. So this went up. Obviously, one of the things you're going to find is that if you do not innervate the muscles appropriately, you're going to have loss of contraction of those muscles, and they tend to atrophy very, very quickly. So if you ever see someone with like a spinal cord injury or something, where they've lost that good innervation of some muscles, you find they tend to atrophy pretty quick, as the case may be. And again, we'd like to make sure that they try to stay active. We tell these older patients to make sure they stay active and moving around, because otherwise, they're going to have this muscle wasting that occurs. It can lead to what we call sarcopenia. Basically, they're losing performance and strength of the muscles themselves. Right. Okay. So how do we adapt to strains on the muscle? Obviously, we have hypertrophy. Again, if I were to increase the number of muscle cells, what would you call that? Hyperplasia, right? That's not actually what's happening here, right? So we're taking the muscles we already have and are trying to increase the actual size of them, and that's why it's hypertrophy, right? And typically what you're going to find is that, especially the type 2 muscle fibers, they tend to get thicker because they actually are increasing the amount of actin and myosin that's available. So typically you're making more sarcomeres, not necessarily actually getting more muscle fibers in general. And of course, if we're not using the muscle, that's when we have atrophy occur there. Again, as I mentioned, if you don't use it, you lose it. And then also things like, adjustment for muscle length. So again, if you have chronic stretching of the muscles, this can also do things like increasing the sarcomere that are attached to the tendon. So you kind of increase the muscle from the tendon end of things and make them a little bit more functional there, right? So again, that's why you want to make sure you stretch normally, because otherwise those muscles tend to get stronger, but then they're a lot shorter, and then you lose some mobility there. So I remember watching there's a documentary on bodybuilders, and they're talking about like having a hard time even going to the bathroom because they couldn't really reach around and wipe themselves because they had so much muscle mass and no mobility, and it was kind of a problem, right? So again, hopefully you'll never be in that situation, but find a caregiver that can help you out with that sort of thing if you are. If you turn into Mr. Universe, or Mrs. Universe, as the case may be. Anyway, so some other muscular phenomena that can occur here. Anyone ever heard of rigor mortis? Some of you look like you might have experienced that in my class once or twice. Just kidding, no. So this is after death. Answer a test or something, but basically several hours after the body has died, it's going to go in this kind of state of very strong contracture. And basically what's kind of interesting here, what's occurring is you're losing ATP, right? So again, when the body is dead, you're not producing new energy here. And we mentioned that what helps the myosin head dissociate and kind of reset itself? ATP, yeah, the ADP and phosphate leave, and then ATP binds to it, and that's what causes the resetting of it. So in these patients who are now dead, you're going to find that they have no ATP to bind to the head and kind of reset it. So they stay in this really contracted, or this strong state of contraction, where if you find someone several hours after they died, you may not be able to move their muscles very much. That will degrade over time because actually, as you have degradation of the proteins themselves, they'll start to break down, and then the patient can be a little more mobile, as the case may be, right? So that's one case. Typically, you need about 15, 25 hours later. That's when that starts to occur there. I actually got a chance to go to the Orange County Medical Examiner's office, and so it was really cool. If you ever get a chance to talk with them, what's interesting, this is a bit of a digression. So did you know that there's a difference between a medical examiner and a coroner? There is. A medical examiner is a physician, right? They had to go through pathology and they get special training in actually being a medical examiner. The coroner is just someone who got a certificate. In Florida, we only have medical examiners, but in other states, like if you go to Georgia, they can have coroners there that work. And so it's really interesting because like the level of quality of actual autopsy and things like that you get is going to be obviously a lot greater with someone who's had years and years and years of training versus someone who got a certificate, right? So I don't know if any of you are related to coroners. I don't mean to speak any shade, but this is at least what I was getting from the medical examiner I was talking to. So she was biased. Yes, sir.
So what's the death investigator then?
I did not ask her that specifically, so I cannot say. However, they are very open to doing tours nowadays. So if you ever want to go and talk with their medical examiners, they're more than open to that. Actually, you guys ever remember like Dr. G medical examiner? So that she was based out of Orange County, and for a long time they wouldn't let students and stuff in. But I had a class where I was like, "Oh, can I take my students in?" And they said yes, and so we got to. It wasn't here, but anyway.
So just to answer the death investigator,
Okay.
because my sister does it,
Oh.
It has no medical training. It's really just for people who go into the criminology field. And then they study all the theory, and then they're the ones that go on scene and check everything out.
Very cool. So they probably deliver a lot of information back for the medical examiner to work off of when doing all of that. She's also very okay with handling bones without any kind of gloves on. We all thought that was really gross, but she's like, "What's a bone going to transmit to me? This thing has been dead for years." And I was like, "Okay, I guess that makes sense." But anywho. All right, so off that tangent. So anyway, other things like muscular dystrophy, we actually run into this with some pediatric patients. These patients tend not to live quite as long as others without this. But here's an example of something called Duchenne's muscular dystrophy. It's a male-only sort of disease because it's an X-linked recessive disease, and it can actually have mutation of this dystrophin protein. And basically, the cells tend to have this destabilization because they can't handle calcium well. And so here's some examples of some of the kind of muscular changes that occur here. They have a lot of issues with their gait and getting around, being mobile. A lot of other problems that can develop. So again, lots of different muscular disorders we run into. Here's just kind of a few examples you may see. Okay, so any questions so far? All right, so let's talk about the neural control of. First off, we're going to talk about spinal control of the actual motor function itself. So going to the spine, we're going to find that the actual cord gray matter here is where there's a lot of integration of different signals that are going to be happening in here, right? So again, we're going to typically find that the anterior horn here is going to be kind of related to the motor neurons that will actually innervate the muscles. We're going to find that the sensory horn here is going to be in the dorsal portion. This is where all the information is going to be traveling in. Now, again, to keep myself standing here, does every single signal have to make it up to the brain to make it back down to the muscle to keep me upright? Not really, right? You're going to find that a lot of that signal does go up. However, there's a lot of direct communication. There's a lot of reflexes that happen based on sensory information coming into the dorsal aspect of the spinal cord that will then get integrated here and then get traveled back out to the muscle itself through the anterior horn. Okay, this is going to be done with a lot of these interneurons. They're going to be communicating to the anterior motor neurons to say, hey, you're tipping too far forward. Let's go ahead and relax those muscles and contract the muscles that are going to bring you back, and vice versa, right? So again, just one example there. You can see one branch is going to terminate in the gray matter itself, and it will elicit those cord reflexes. The other branch tends to travel higher up in the nervous system, where we can then start to integrate a lot of information about things like, okay, what's my position in space? Like, how am I moving? Things like that. So here we're going to look at the anterior motor neurons. So we're going to see here there's going to be what we call alpha motor neurons that actually innervate the actual skeletal muscle itself. This is what actually activates the motor unit to cause the actual muscle contraction itself, okay? There's also what we're going to have are going to be these gamma motor neurons that innervate what we call the intrafusal fibers, okay? So imagine here, you have the actual muscle itself, you're going to find, or a muscle fiber, you're going to find they have the alpha motor neurons that will innervate the muscle, cause the contraction. We also have these gamma motor neurons that are going to be located here in these intrafusal fibers, okay? Now, these intrafusal fibers here don't actually have, especially in the middle, don't really have any actin or myosin. These are mainly going to be more sensory. And you can see here they have these sensory neurons. They're going to be able to detect changes in length of the muscle itself and be able to transmit that back up to the spinal cord, okay? Another way of looking at this is going to be looking at the entire muscle here. So again, imagine the motor end plate. This is what actually causes the actual depolarization to occur here. You're going to have the muscle spindle is going to be able to send information back up into the spinal cord saying, hey, here's the length of the muscle occurring right now, if it's changing at all. And then it's going to be able to send out reflexes back to make an appropriate change in the muscle. I'll just give you some examples here in a second, but basically this is trying to determine what the state of the muscle is, whether it's moving, getting shorter, longer, whatever it happens to be, send signals back up so that way you can have a reflex that comes out here, okay? A little bit later, we'll also talk about the Golgi tendon organ. This is going to be good about talking about stretch in the actual tendons themselves, okay? That information will also be integrated to try to help us out with the muscle, right? Okay, so again, this is going to help us, that controls the actual tone of the muscle. When I say tone of the muscle, what do you think I mean? As I mentioned, are all our muscles like normally just flaccid until they're ready to be used? No, they're going to be under a kind of a baseline state of contraction, right? You don't want to have absolute zero tone in there. That's why I always think it's funny when people say, I'm going to get toned up. And I'm like, okay, so you're going to be like really contracted and... No, you're basically what they're trying to do is called muscle hypertrophy. But what you're finding here is that the tone itself has to be kept at a certain steady state, especially for my postural muscles, things are keeping me standing. All these muscles need to be contracted at a certain state. Otherwise, if one set of them, say my hamstrings all of a sudden just went to zero tone whatsoever, I'd probably just fall backwards, right? I think so. Whatever way it would fall. It would not be pretty, right? So anywho, so here's what the muscle spindles are helping us to do is make sure we can determine what that length of the muscle is and have appropriate reflex arcs. Okay, they also have what we call the interneurons. These are going to be found basically in all areas of the cord gray matter. They are small and very excitable, and they have lots of different interconnections itself. And very rarely do you have a signal coming from the CNS traveling down that actually directly innervates the muscle itself. Most of the time, they're going to be communicating with interneurons to eventually integrate a signal and travel out to the muscle then, okay? Also, some other cells you might find here as well are going to be things like Renshaw cells. These are going to be more inhibitory neurons that allow for that lateral inhibition to occur. You remember when I said lateral inhibition instead at the beginning of the class, what that was? So instead of like, say 2 strong signals coming in at the same time, maybe contracting too many muscle unit or motor units at one time, it is able to kind of have an inhibitory effect. So that way you only get really the signal that you're looking for at one given time. Again, we're not going to talk about these greatly here, but they allow for that lateral inhibition effect that occurs. You can read up more on that if you like, but that's one thing that does. We also have things like propriospinal fibers. These are actually good because they can communicate between different segments of the body. So say from like, say, one side of the body to the other, that allows us to help with things like, okay, what's our position right now? Do I need to maybe contract one leg to counteract what the other leg is doing, etc. Right? Okay, so let's talk about the actual sensory receptors themselves. As I mentioned, we need to make sure we have proper information that's coming in. So proper sensory information coming in from the muscle spindles and also from the Golgi tendon organs, right? So this is detecting what the actual tension in the tendons are going to be. This is detecting the tensions actually in the muscle itself, okay? Again, here's the green and blue signals. They're going to be coming up through the sort of the sensory, the dorsal root of the ganglion here, and they're going to be communicating. And then usually with these interneurons, some signals are going to get traveled up to the CNS, and then other signals are going to be traveling back directly down into communicating with these motor end plates here. Right, here's the alpha muscle fibers here, motor fibers. Here's going to be the gamma ones. Right, notice the gamma ones are going to be innervating either side of the muscle spindle. That'll be important here in a second, okay? Basically, this is good for kind of subconscious control, this kind of intrinsic muscle control. Some of this information is going to be sent to like places like the cortex and cerebellum, but a lot of this is going to be related back to reflexes. They're going to keep me upright or keep my muscle at a certain set tone, whatever the case may be, right? So basically, looking at this more in detail, again, you have roughly, like, say, 3 to 12 kind of intrafusal fibers that are found basically in the belly of the muscle, right? So kind of right in the middle there. Again, they're going to have no actin or myosin. So right here where these sensory fibers are, there's really no actin or myosin going to be present. So this area right here, can it make any contractions? It can't, but with these fibers here, it's able to detect, is it being stretched or is it being shortened up? And so by sending that information up into the spinal cord, it can give you lots of information on basically what the muscles are doing, essentially, okay? So I mentioned the gamma motor neurons are going to be connected to the spindle ends here on either side. These will be able to contract that muscle there, these fibers. However, right in the middle here where the sensory fibers are, there's no contraction actually happening, okay? That'll become important in a second. Now what will normally happen, and again, when you have the spindle receptors actually being excited here, say for instance you have the muscle being lengthened out, right? So say for instance I was pulling on the muscle, I was making it longer. What do you think happens to these fibers here? Do they get longer as well? Yeah, because they're getting stretched out, right? They're getting pulled just like the rest of the muscle is, right? So imagine I'm not actually stimulating any kind of contraction, but I'm pulling the muscle, right? And again, you'll see this when you're like testing for things like reflexes. I'll show you what that looks like in a second. But basically, imagine if you're pulling that muscle there, this receptors here are going to get stimulated. They're going to say, hey, the muscle's lengthening. That signal can then get traveled back up to the spinal cord and say, hey, the muscle's lengthening. What do you think the muscles wants to do in response to that to maintain their normal tone? Let's say, well, they're too long. I'm going to try to contract. Right, that's a reflex, right? So again, when you have these being excited, it's usually because the muscle is being lengthened out. It's then going to send a signal up and say, hey, well, we need to contract that muscle back down to make sure it stays right where we want it to be. Okay, so imagine if someone were to throw you something heavy, right? So again, my muscle or my arm is staying in this position here. Someone throws something heavy, instead of the arm just going down, I can try to have that reflex as that muscle start to get stretched out, do that heavy load. I can then cause a reflex to try to make sure I keep it in the right position. Okay, that's kind of one example how you might see that. All right, so again, these are responding to stretch. Typically, they're going to be activated when you start to stretch that muscle out, okay? Now, what you're also going to find is that typically the alpha motor neurons and the gamma motor neurons here, they're typically going to both, when you activate the alphas, you're going to activate the gammas at the same time here. That's going to be important because, say for instance, I want to contract the muscle itself, right? So normally, as I contract the muscle, it should do what to the muscle length? Should shorten it, right? Okay, good. So if I shortened it, what would it do to the sensory fibers, do you think? Well, you think it would shorten them as well, and that would send an inappropriate signal to the spinal cord saying, hey, the muscle's getting shorter, we need to do something about this. However, what's kind of cool here is when I'm actually signaling the alpha motor neurons to fire off, I signal the gamma ones to fire off as well. So as I'm contracting, the muscle's getting shorter, both ends of this are getting contracted as well. And what do you think it does to the middle? It actually stays the same. So when I'm under voluntary control, I'm telling my muscles to shorten, I don't have a reflex that says, hey, you need to lengthen the muscle back out, because I'm both contracting the alpha portion here and this gamma portion. So the middle here actually stays the same. Make sense? The alternative is correct as well, is when I say I'm relaxing the muscle and say I'm decreasing activation here, I'm also decreasing activation of the gamma motor neurons, and that should cause the middle to stay what? Should stay the same, right? Because again, as these are relaxing and it's causing the muscle to lengthen back out, These are also relaxing, which is actually is going to release tension here right in the middle, and it should stay roughly the same. So this is how we kind of prevent inappropriate reflex arcs. When I'm trying to say, hey, bend your and you flex your bicep, I'm not causing an inappropriate reflex. Hey, go ahead and try to lengthen them back out. Okay? Everyone with me so far? Okay, we can go back and review this. It's a difficult concept, but I think once you kind of get the hang of it and you think about these reflexes, it makes a lot more sense. Or it doesn't, and then we're just totally lost forever, but it's okay. You at least have a 25% chance of getting the questions right on the test. So anyway, so just before we wrap up, so again, looking at the sensory fibers, it's kind of interesting. You actually have two kind of different types of sensory fibers here. So we have, like, say, like the 1A, which are going to be kind of innervating both of these type of intrafusal fibers. So again, some of these are, we call it a nuclear bag fiber. Again, not all these names are super elegant. But you also have this nuclear chain fiber itself here. And what's interesting is that when you cause slow stretching of these fibers here, you're going to find that these stretch here is going to be kind of proportional between both of them, which means they're both going to be kind of stretched at the same rate there. And so we're going to call this basically a static sort of response here, right? So again, they're both going to be stimulated roughly at the same time. This is going to be for like kind of slow changes in the muscle size. However, if you were to have, say, sudden changes, you're going to find that this one tends to get signaled a lot more strongly. So this nuclear bag fiber is going to be the one that gets bigger signal first, and that's going to be more of a dynamic response, right? So again, if I threw you something heavy and you catch it and you're trying to prevent that rapid change in muscle size, those dynamic responses was going to be the first thing that kind of initiates that reflex to try to prevent that muscle from stretching out, right? Again, you can kind of see this when you're looking at a stretch reflex. Imagine, looking at the stretch reflex, or in other cases of relaxation, can kind of be either in this case. But as I were to stretch out a muscle, it's going to do what to the muscle spindle? It's going to lengthen that one out too, right? And it's going to cause what reflex to occur? It's going to feed back and then cause that muscle to want to contract back down, right? Because again, we want to make sure we're keeping but roughly the same length on those fibers, because again, whatever the brain has set as the normal tone there, we want to help to maintain that, right? So again, if you imagine if you're trying to elicit a reflex, say from the leg, right? So you strike the patella, what happens to the leg? It's going to go up, right? So you're going to extend your leg out. Why does it do that? When I strike that tendon there, what does it do to the muscle? It lengthens it out temporarily, right? So for a short period of time, it's going to lengthen that out. And so what does that muscle say it needs to do in order to try to get back to normal size? It's going to want to contract, right? So that makes sense why you actually had that reflex that happens there, right? Where your leg kicks out when you strike that tendon, right? Same thing is happening here. This is the exact same phenomenon we're looking for when you're trying to elicit those sort of reflex responses there. And again, it's basically just trying to oppose sudden changes in muscle length. So if all of a sudden I start to fall over for whatever reason, I can respond to that appropriately due to those rapid changes in looking at that reflex there. My brain doesn't have to tell me to make sure you try to balance yourself, but the body's going to be able to do that on its own to some degree. That make sense? I'm going to cover this again next time we meet, just to make sure it kind of like solidifies itself a little bit. So if you don't have it now, it's okay. We'll talk about it again just a little bit. Okay? Most of you guys are probably pretty done right now. That's okay. You guys want extra 5 minutes to kind of like sit here and like kind of perseverate on this topic here for a little bit? Is that okay with you guys? Okay, so I'm going to let you go now. Any questions before I release you? Okay, we'll cover this again. If you have any questions on the test, or if you feel like your grade did not update as it should have, come see me, please, right now, and we can go over it. Thanks.